going to talk a little bit about the most common operation performed for pancreas cancer, which is the pancreaticoduodenectomy or Whipple operation. And before I do that, I'd like to discuss the normal anatomy so I can describe what the operation entails. What you're looking at on this slide is the normal anatomy of the upper abdomen. In the central aspect of the cartoon, you can see the stomach, which is supplied by arteries in red. Towards the top of the diagram, you see a little bit of the liver, which was actually cut for purposes of illustration here. And then behind the stomach, just above the stomach, you can see the pancreas peeking out. By this picture, it's very easy to see that the pancreas, again, is in very close approximation to some very important arteries, which are in red, and veins, which are in blue. And again, it's this anatomy that poses one of the many difficulties that we have with treating pancreas cancer. So this slide depicts the normal anatomy as we would see it surgically. In reddish brown at the top is the liver. The gallbladder can be seen in green. The bile duct is connected to the gallbladder and is the tube that drains bile from the liver above into the small intestine below. The stomach is easily visible, and behind the stomach you can see the pancreas itself. Note in the pancreas, the pancreatic duct, which drains, again, pancreatic digestive juices from the pancreas into the small intestine, and in fact typically drains those juices through a common channel with bile coming from the liver through the bile duct. So food that is eaten comes down the esophagus, which you can't see, goes into the stomach. That food is then processed. The food is excreted into the duodenum, or the first portion of the small intestine. It's mixed with bile from the liver and pancreatic digestive juices from the pancreas, and then that processed food mixed with enzymes and bile is excreted into the remainder of the small intestine. You also see in this picture the large intestine, which is further down in the anatomy. What you see here in this slide is the anatomy that is involved in a pancreatic cancer resection. What I'm talking about here relates to tumors in the head of the pancreas. Tumors in the head of the pancreas account for approximately 2/3 of new cases of primary pancreas cancer, but actually the number of these patients with head tumors far outnumbers the number of patients with tumors elsewhere in the pancreas who are brought to surgery for a number of different reasons. But again, this operation that I'm describing is for patients with tumors in the head of the pancreas. So what this slide depicts is the anatomy that is removed at the time of the pancreaticoduodenectomy or Whipple procedure. You can see here the organs that are divided as part of this procedure, because it's important to recognize that unfortunately we can't remove only the pancreatic tumor itself. We have to remove a significant amount of anatomy that surrounds the primary tumor. In the case of this particular operation, which is the most common operation performed for pancreas cancer, we must remove the gallbladder, the lower aspect of the common bile duct, or the tube that drains bile from the liver to the small intestine, the head of the pancreas, the first part of the small intestine called the duodenum, and in many cases a part of the stomach. So what you see here is that the stomach has been cut, the small intestine has been cut, and the pancreas has been cut. And this single surgical specimen in the middle of the diagram is what is removed as part of a standard pancreaticoduodenectomy procedure. Once we remove that portion of anatomy, we have to re-establish gastrointestinal continuity, meaning we have to connect all these things that we've divided. So we bring up the small intestine and attach it to the pancreas, and then we attach it to the common bile duct, and then we finally attach it to the stomach. And that allows food, which is eaten, to come through the stomach and then flow directly into the small intestine and go distally. Pancreatic juice takes a more circuitous route. It goes through the pancreatic duct into the small intestine, mixes with bile, and then goes down that loop of intestine out to the large intestine. You see here on the left aspect of the diagram 2 drains, which are often placed after the operation. I typically use 1 drain. Some people use no drains, as well as 2 tubes that can possibly be placed during the operation as well. Some surgeons place a tube in the stomach, as you see here, to help the stomach decompress and prevent dilation of the stomach. And some surgeons put in a tube in the small intestine, such as the one you see here, to assist with the provision of nutrition following the operation. The use of these tubes is optional. I typically do personally, put in a small intestinal tube to feed patients temporarily, but I rarely, if ever, put in a tube into the stomach. As you can see from these slides, this is a fairly complex operation. The operation can take anywhere upwards of 3 to 4 hours to complete. Typically takes on the order of 5 to 6 hours, but certainly can take more depending on the complexity of the tumor, the relationship of the tumor to other organs and other blood vessels, and on the basis of the patient themselves. Typically, after this operation, patients stay in the hospital on the order of 10 days, anywhere between 1 and 2 weeks, and recovery can take some time. I tell my patients personally that they will not recover 100% for about 6 months, so they won't feel as good as they do prior to the operation for 6 months. Now, they feel pretty good at about 3 months and even earlier, but it takes a full 6 months to recover 100% from this operation, in my view. Recently, there have been some technical advances in pancreatic cancer surgery. Many surgeons now have gained experience with minimally invasive approaches, and many patients are requesting to at least learn about these different approaches to pancreatic cancer surgery. Minimally invasive surgery is typically performed through multiple small incisions, as you see in the upper left-hand portion of this slide. Trocars, or these tubes, as seen in the lower left-hand portion of the slide here, are placed through these small incisions into the abdomen, and then the abdomen is inflated with gas. And this provides working room within which instruments, such as the ones in the lower right hand of this slide, can be inserted into the abdomen and the operation can be performed. The entire operation is visualized on video screens. Theoretically, these operations are associated with lower length of stay and less pain, but the advantages associated with these operations have not yet been definitively proven. And at this point, particularly for cancer, I think their use should be restricted to certain centers and certain patients, preferably in some sort of experimental trial format. Robotics have also become an option for pancreatic cancer surgeons. Robotics, such as the robot depicted here, offer enhanced magnified 3D optics and imaging, improved dexterity over earlier generation laparoscopic technologies, and are ergonomic for the surgeon, which makes these long operations somewhat more comfortable for the surgeon. What you're looking at here is a surgeon on the left operating at the robotic console across the room from the surgical robot with its multiple surgical arms positioned over the patient lying in the center of the screen. These robots are actually quite incredible. They offer 3D views with high-definition optics. They give a wide angle of the surgical field. You can zoom in and out, and in fact, you can see small aspects of anatomy more brightly, more sharply, and more clearly than this anatomy is even viewable in a standard operation. But it's important to remember that these robotic and laparoscopic operations are not right for everybody. Certainly, patients with advanced tumors are often not a consideration for these techniques, and only certain individuals with extensive experience with these techniques should be performing them. So whatever the route taken, whether it be by a minimally invasive or standard approach, the Whipple operation is associated with certain postoperative changes that, again, are due to body changes that occur secondary to removal of the pancreas and changes in the pathways that food must use to go from the stomach out through the body. First of all, removing some of the pancreas can lead to diabetes. I typically tell my patients that if you're not diabetic prior to the operation, the chance of becoming diabetic after the operation is about 10%. And when I say diabetic, that typically does not mean insulin requiring, but it does mean that about 10% of patients who are not diabetic require some sort of oral medication to control diabetes after the operation. Diabetics who undergo the Whipple procedure, about 10 to 20% of them can anticipate worsening in their diabetes following the operation. The second issue is exocrine insufficiency. Patients who lose a piece of their pancreas may have some difficulty digesting food the same way that they did before due to the relative absence of digestive enzymes and the different anatomy of the small intestine. We typically recommend that oral pills are used to replace digestive enzymes after the operation. These pills are typically taken with each and every meal. Finally, there are dietary changes that come about again, both because of the altered pancreatic anatomy and altered small intestinal anatomy. I typically advise my patients to eat frequent small meals as opposed to 3 meals a day, and to limit their dietary choices to choices relatively low in fats. A common question I'm asked in my clinic by patients who are considering this operation is, what will my life be like after? And there have been several studies which have documented quality of patients' life following surgery. This is some of our own data from my group here at MD Anderson, in which we evaluated various questions assessing a patient's quality of life. All of these patients were asked these questions after surgery as they embarked on their postoperative chemotherapy. And we followed their quality of life by having them answer this series of questions at various time points from surgery all the way till the 5-year mark after surgery. And what you're looking at in this slide is a summary of the group's response to the question, to what extent have you been troubled by side effects of treatment? And on the y-axis, you can see the responses varying from not at all to very much. And along the x-axis, you can see the time point that the questions were asked. And what this curve that is generated from these data points shows is that early after treatment, between the baseline measurement and 3 months, the side effects were somewhat troublesome. But those troubles resolved by 3 months, and at the 3-month mark, stayed fairly minimally bothersome until the 5-year mark or 60-month mark. This slide shows the responses from patients asked 2 questions. Number 1, on the top, how would you rate your overall health? And on the bottom, how would you rate your overall quality of life? On the y-axis are responses from very poor to excellent, and on the x-axis are the time point at which those responses were obtained. Baseline, meaning immediately following surgery, through the chemotherapy, and then measured at 3, 6, 9, 12, 15, 21, 24, 28, 32, 36, 42, 48, 54, and 60 months following surgery. And what you can see in both of these curves is that patients, in general, rate their overall health not very well immediately after the operation, but by 3 to 6 months feel like their overall health is good and that their overall quality of life is close to excellent. So last I want to touch on the volume-outcome relationship. That is the relationship between the number of procedures performed by a surgeon or at a hospital and the short and long-term results of their patients with surgical therapy. And what I want to show you in this slide is that while I've described a single operation to you, that operation can be performed a number of different ways, and the results obtained by that operation are quite variable. And one of the most important things that can affect the outcomes associated with a surgeon's operation that they perform is the number of operations they do perform on a yearly basis. At the top of this slide, you can see a chart which shows the number of surgical cases, the estimated number of patients treated yearly, and the operative mortality, or the number of patients, or the percent of patients that die from pancreatic cancer operations in hospitals who treat very low, medium, high, and very high number of pancreatic cancer patients. What you can see, first of all, is that to be rated a very high volume hospital for pancreas cancer, you only have to operate on 13 pancreas cancer patients yearly. Most high-volume pancreas cancer centers, such as MD Anderson or Johns Hopkins or Mass General or any of these other pancreas centers, operate on well over 100 patients yearly. But you can see in this table that, at least according to this system, very high-volume hospitals were those that treated greater than 13 patients per year. What you can see here in this slide is that patients who were treated at very low-volume hospitals have a risk of death from the operation that I described to you before of approximately 16%, whereas patients who are treated at hospitals who treat a large number of these patients have a risk of dying from the operation of only 4%. So it is imperative that patients with pancreas cancer seek out treatment facilities that are familiar with pancreas cancer treatment and treat a large number of these patients. On the lower left aspect of the slide, what you're looking at is a chart that is comparing on the y-axis the life expectancy of patients treated at different hospitals, and on the x-axis, the type of hospital they were treated at. Again, whether they were very low-volume hospitals, medium-volume hospitals, high-volume hospitals, or very high volume hospitals. What this chart is showing you is that the difference in survival, on average, of patients treated at very high volume hospitals is almost 2 years longer than the median survival of patients treated at very low volume hospitals. So what you're looking at in the lower right is a chart that shows that the difference in survival seen by patients treated at low and high volume hospitals can not only be explained by differences in complications or problems that occur in the perioperative period. So the fact that patients treated at high-volume hospitals live 2 years longer than patients who are treated at low-volume hospitals is not only because the mortality rate from surgery is higher in those low-volume hospitals. There also is something to do with the way that the operations are performed in those high-volume hospitals. That is, while the operation may seem standard from one institution or another, there are subtle differences in the operations that are performed that can lead to long-term differences in cancer-related outcomes. So I mentioned that surgical therapy is the only treatment that has historically been viewed as curative for patients with pancreas cancer. But let me show you this survival curve. Again, this is a Kaplan-Meier survival curve, meaning that on the y-axis, what we're showing you in this slide is the percentage of patients that are still alive after surgery for pancreas cancer at any given point. And those time points are the number of months following surgery as shown on the x-axis. And again, the flatter and higher a line is indicates a group of patients that are doing better over time. Well, the first thing you can see in this slide is that, again, these are all patients who have undergone pancreas cancer surgery for resectable pancreas cancer, but none of the curves on this chart are flat. That indicates that the rate of actual cure following pancreas cancer surgery itself is actually not 100%. And in fact, even in the best curve in this slide, the rate of cure is about 20%, or the number of patients who are still alive after potentially curative pancreas cancer operations after 5 years is only about 20%. The second thing that's important to recognize in this slide is that despite improvements in perioperative care and operative techniques that we've been making over the past 30 to 40 years, there have not been significant changes in the outcome of patients following pancreas cancer surgery throughout that time. So what this slide is actually showing you is groups of patients with resectable pancreas cancer who underwent surgery in the 1970s, in the 1980s, in the 1990s, and then in this last decade. And unfortunately, what this slide is showing is that the survival rate of patients treated in all of those 4 decades are relatively equal. Well, why is that? Well, this is a famous paper which shows what is going on with pancreas cancer on the cellular level. And in fact, when I have patients that are newly diagnosed with pancreas cancer, many of those patients believe that those tumors have been growing over the past several days or maybe several weeks. Some may believe those tumors have been there even for several months. But in fact, what this slide actually shows is that the initiating events for pancreas cancer development and pancreas cancer growth may occur 10 to 15 years prior to the diagnosis of pancreas cancer clinically. Once those cellular events occur, tumors begin to grow and may disseminate early in the growth process. What this cartoon is showing is that cells in maroon are breaking off from the primary tumor in this presentative patient about 6.8 years prior to diagnosis. What that means is that when we diagnose patients with pancreas cancer, certainly many of them have disease outside the pancreas when that cancer is diagnosed, but what it also implies is that patients with localized cancers or cancers that appear to be localized on CAT scan also have cells either floating throughout the bloodstream or cancerous cells in the liver or lungs that cannot be detected by CAT scan or other imaging methods.
Thanks for listening. If you like and learn from our GraceCasts, you can subscribe on iTunes by just searching for the term Cancer Grace, find podcasts in the subject you want, pick a format of audio or video, and then just click subscribe. It's that easy. And for those of you who don't want to miss any of our programs, there's even a feed for all subjects. You can also find us on YouTube at Grace for Cancer Info, and that's the number 4 in one word, Grace for Cancer Info. Finally, if you haven't been there yet, please check out our Grace website at www.cancergrace.org. And don't forget that donate button in the upper right. Our content, which helps tens of thousands of cancer patients around the world every month, is made possible by your support.